have very important topic, and almost every alternate year it will be a long notes or some part of this topic will be asked as a short notes in your final examination. So we have a case today. This is a 5-year-old boy who fell from monkey bar while playing. So after the fall, patient noticed pain and swelling of the left elbow joint. So, and when we did clinical examination, a pointing finger, there is no flexion possible. So there is a deficit of flexor digitorum profundus and superficialis. So, and there is feeble radial pulse, but hand is pink. So this is a case of elbow injury. There is injury around the elbow joint. So most common injury around the elbow joint is supracondylar humerus fracture. So this patient, as I told you in clinical examination, there is some problem with the flexion at the pointing finger. So this direct you towards the median nerve injury. And there is feeble pulse, means there is some problem with the brachial artery. So this is not a simple fracture. There is a fracture along with compression or involvement of the nerve and also involvement of the vascular tissue. So it's a supracondylar humerus fracture. Here you can see the mechanism of injury. Patient has history of fall on outstretched hand. So how will you define a supracondylar fracture? So supracondylar fracture is a metaphyseal fracture. It occurs at the distal metaphysis of the humerus. And what is the extension? It extends from the ridges, supracondylar ridge to upper border of the trochlea. Any fracture in this area, we consider it as supracondylar humerus fracture. So any fracture in this area, that is distal metaphysis extending from supracondylar ridges to upper margin of the trochlea and capitulum, is considered as supracondylar humerus fracture. So it is most common elbow injury. So just to recall here, what are the most common pediatric injury? First is distal radius. Distal radius is most common, followed by phalanges, finger injury, then followed by elbow injury. Along the elbow injury, the commonest fracture is supracondylar fracture. So this is the common third most common site of injury in pediatric population. So here you can see distal radius followed by phalanx fracture, elbow. Clavicle is the fourth common fracture in pediatrics. So the prevalence is 5 to 7 years age. So why the supracondylar fracture is more common in children? Because the supracondylar area is present as a thin bone in the children, and anterior capsule is very lax. So it gives hyperextension injury when patient has fall or stress over this area. So before going to the topic proper, we need to know what are the important structures located in relation with the supracondylar. As I told you, the supracondylar ridges to upper border of the trochlea and capitulum, we have supracondylar. So this all is supracondylar area. So in this we have, this is on medial side. This is lateral side. So what we have on the lateral side, the nerve coming here, that is radial nerve. On the medial side, we have ulnar nerve. And this is your median nerve. The red one is your brachial artery. And this median nerve is dividing here, and it's an anterior interosseous nerve. So just to recall, anterior interosseous nerve, it's a branch of median nerve. Here we have anterior interosseous nerve. The red one is the brachial artery. Then this is the median nerve here, ulnar nerve going posterior to the medial condyle. Then we have radial nerve coming from posterior to anterior, and the lateral condyle here. So these are the important structures located in and around the supracondylar region, and they are likely to get injured when patient has supracondylar fracture. So this is one more important thing here, because it is commonly asked in your exam. So how is the appearance of the growth plates? Appearance of physis in distal humerus. Distal humerus. So just remember the mnemonic CRM, CRIM, TOL, tall. CRIM tall. What is CRIM tall? Capitulum, radial head. This is very important. You need to remember it. Medial left condyle, then trochlea, olecranon, lateral epicondyle, lateral condyle. So this differs with a 1 year. So this is like 2 years, 2 years, 4 years, 6 years, 8 years, 10 years, 12 years. This is how the series of the physis which appears around the distal end of the humerus. This is very important because they help in estimating the age of the patient. And second thing is, it is repeatedly asked in your examination. So you need to remember this mnemonic. You need to remember this one. So as I told, capitulum. So as you see here, this is your capitulum. So this is first to appear. Then radial head, two. Then third is medial, third. Then fourth is trochlea. Fifth is olecranon. Olecranon will be this one, fifth. Then sixth is lateral. So this is the series of appearance of the growth plate, physis in distal end of the humerus. So this you need to remember. Uh, uh, there is no other option. Then there are three radiological parameters which are very important. One is anterior humeral line. What is anterior humeral line is when you take a lateral view and you draw a line along the anterior aspect of the cortex. So this is the lateral view. So anterior cortex, if you draw a line like this, it should cut the capitulum. So it should cut the distal physis. So the distal humerus physis should lie little and should be divided. I mean, it should be part should be anterior to the anterior humeral line. This is very important parameter. The second is metaphyseal-diaphyseal angle. So this is your prominent part here, prominent part here. If you draw a line, this is metaphyseal line. If you draw a line along the long axis of humor, this is diaphyseal line. Diaphyseal-metaphyseal line, this angle should always be 90 degree. And the third one is ulno-humeral angle. This is the line along the long axis of the ulna, and this is along the long axis of humerus. This angle is called as ulno-humeral angle. It's around 15 degree. Then the third one, very important, is Bowman's angle. What is Bowman's angle? Is you draw a line along the articular surface distally and along this physis here, like this. So the this angle form is around 75 degree. This angle is very important. It is called as Bowman's angle, but it's not the same in every patient. So it differs from patient to patient. So what is the easiest way to check this angle is take the X-ray of the normal side and compare the angles with the normal side. So one hand is fractured, other hand is normal. So you take the elbow of normal elbow joint and X-ray of normal elbow joint and take the X-ray of the affected or fractured limb and draw the angles and measure this angle. So you can find the difference. So most of the time, the same patients, the other limb which is normal is used as a control for calculating this angle. So anterior humeral line, metaphyseal-diaphyseal angle, humero-ulnar angle, and last one is Bowman's angle. All four angles are very important in reading the X-ray or estimating the amount of deformity or amount of malalignment. So how will you classify supracondylar humerus fracture? So this classification goes by name Gartland's classification. This is very important and many times it will be asked in your exams. So if you see here, this is the distal end of the humerus on the lateral view. So this is diaphysis, this is metaphysis, and the distal end of the humerus, this is periosteum here. So this is your anterior aspect, this is your posterior aspect. This is the presentation of normal elbow joint. So what happens in flexion deformity? If you see flexion fracture, the fracture, there is a fracture in the supracondylar area and distal fragment is moving anteriorly. So anterior displacement. So this is how it appears. So this is your distal fragment. This is your anterior displacement of the distal fragment. So this type of fracture is called as flexion. So inflection type of injury. It is very less common. Only 2 to 5% of the supracondylar fracture are flexion type, because most of the time it is an extension type of injury. Extension type of injury is if this is the elbow, the distal fragment is moved posteriorly to the elbow joint. So this is proximal fragment, distal fragment, elbow joint. So it has moved to distally. So this is the extension type of injury. So among extension, we have three grades: type 1, type 2, and type 3. Type 1, if you see, it is undisplaced fracture. So if you see here, there is a fracture line here or fracture line here, but it is undisplaced. So periosteum is continuous. So there is a undisplaced fracture. So here it is stable and well reduced. So we have well reduced and stable fracture here, that is type 1 Gartland. So type 1 Gartland, there is a fracture, but there is no displacement and the fracture is very stable. So this is how the type 1 fracture appears. Then what is type 2? Type 2 is partial displacement. If you see, the posterior cortex is in continuity, whereas anterior cortex has breach. So there is a breach in the cortex and anterior periosteum is damaged and the fracture has moved posteriorly. So it is moderately stable. And also it is displaced, but not very much. So partially displaced. So we need to convert this fracture to this fracture and immobilize it. So that is Gartland type 2 fracture. Then what is Gartland type 3? Gartland type 3 is there is complete fracture line with complete displacement and the periosteum is also damaged. So Gartland type 3. Type 1, there is no displacement. Type 2, partial displacement with intact posterior periosteum. Type 3 is the complete damage to the periosteum and posterior displacement. So now the recent classification, they added the type 4 to the Gartland. What is type 4 is? It's again a displaced fracture, but very unstable, very unstable. Very unstable. So it is stable in mediolateral direction and superior inferior direction. So it's the type 4. It's not a classical description or a classification of Gartland. It's a modified Gartland's classification. So this is how you classify. So just to repeat, Gartland classification, supracondylar fractures are flexion type or extension type. Flexion type, just only 2 to 5%. It is less common. Extension type is most common, 95 to 98%. Out of that, type 1 undisplaced, type 2 partially displaced, type 3 is completely displaced fracture. So this is the mechanism of injury. In the extension type, you have indirect injury. Patient has history of fall on the outstretched hand while playing. So whenever there is a fall, there is injury to the distal humerus and patient result in the extension type of the fracture. Whereas flexion type, there is direct injury to the elbow, which causes fracture on the distal end of the humerus. So the injury is happening here and it is pushing the distal fragment anteriorly, resulting in flexion type of supracondylar fracture. This is how the supracondylar fracture happens in children. So what are the symptoms of supracondylar fracture? So patient will have history of injury to the elbow. Then patient will have pain, patient refuse to move the elbow joint. There is gross deformity. If you see here that there is S-shaped deformity like this. So due to a posterior displacement of the distal fragments. If you see here, this might be the anterior proximal fragment. This is the posterior fragment and this is elbow joint. So it is posterior displacement of the distal fragment which give the S-shaped deformity to the distal humerus or at the elbow joint. There will be swelling, ecchymosis and the cubital fossa, and patient, depending on the amount of injury, patient may have vascular or neurological supply. This concept is very important. Why? Patient is having, here if you see, patient is having radial nerve palsy. And here patient is having anterior interosseous nerve, this is a branch of median nerve palsy. Median nerve palsy. Why patient is having is, if you see, this is the medial aspect. This is olecranon, means this is medial aspect. So distal fragment is moving medially. When distal fragments move medially, the radial nerve, which is on the lateral side, it get kinked over the proximal fragment. So distal fragment is displaced medially. So it will cause the pressure or over the or entrapment of the radial nerve, and patient will have radial nerve palsy. Here, if you see, the distal fragment is moving laterally. So if patient has distal fragment, if you see, this is your humerus, this is your radius. So distal fragment has moved here. So this fragment has moved laterally. The distal fragment has moved on the radial side laterally. So the anterior interosseous nerve is getting kinked. So patient will have presentation of median nerve injury, median nerve or anterior interosseous nerve. So let me repeat here. it depends on the displacement of the distal fragment. If you see here, it displaced medially, kinking over the radial nerve. If the distal fragment is moving laterally, that is kinking over the median nerve. So this is how, if you see, this is again, I tried to present you in this X-ray. If you see, this is your radius. Radius lies always lateral. So radius is lateral, lies on the medial. So what happens is the distal fragment has moved medially. So the radial nerve has kinked here. So patient will have radial nerve palsy. Just you see here this again in on the slow phase, you will understand it what exactly I want to explain and how the patient is having radial and median nerve injury. Then how will you diagnose? As I told you in the previous slide, what are the clinical parameters you need to look for? So there is something called as posterior fat part sign. So normally what happens is, due to the undisplaced fracture, there is some bleeding happening here over the fracture side. So this is presenting as a soft tissue side on the posterior aspect. That's called as posterior fat part sign. Here, if you see, there is a posterior fat part sign. It's nothing but the bleeding inside the posterior aspect. So posterior fat part sign for undisplaced fracture or subtle fracture. And when you draw an anterior humeral line, as I told, it should cut the distal humerus epiphysis. Here, what is happening is it is lying posterior to it. So the patient is having fracture here, which causes extension type of injury. If you see, there is a fracture here, it has moved it like this. So this head of the this one is lying posterior to the anterior humeral line. That is, anterior humeral line is the head is the distal end of the humerus is lying posterior to the anterior humeral line. The Bowman's angle, as I told you in a previous slide, you need to draw a Bowman's angle, metaphyseal-diaphyseal angle, and ulnohumeral angle. So once you have diagnosed, how will you treat supracondylar fracture? So what is the aim of the supracondylar fracture? One is we need to have a reduction. So alignment should be good. And second thing is we need to have stable reduction, stable fracture. So it should not displace. So we need to get a proper reduction and proper stability. This is our aim. So if you see grade 1 fracture, as I told, there is a fracture with no displacement and no damage to the periosteum. So this fracture is stable and reduced. So we need to have the alignment of any of the fracture to bring it to grade 1. So if it is a flexion type of injury, it rarely comes with conservative management. We always need to go for close reduction or open reduction depending on the stability, and we need to put K-words. But if we have a grade 1 fracture, grade 1, as you told, it is stable and well reduced. We can just apply the splint and leave it for 3 weeks. If patient is having grade 2 fracture or type 2 supracondylar fracture, we need to go for manipulation. After manipulation, if it becomes stable and well reduced, treat it as grade 1 and apply the splint. But if you feel like it is unstable, and so it's you need to go for open reduction or close reduction with K-words. Whereas grade 3, you always need to go for manipulation and fixation with the K-word. Hope this explains you the treatment plan. So our aim is any type of fracture, we need to get a good reduction and good stability. So any type of fracture, we need to convert it into grade 1. If it is grade 2 and grade 3, that is type 2 and type 3 supracondylar fracture, we need to convert it to type 1 and immobilize it. Immobilize in the form of, if it is stable, just by application of plaster. If it is unstable, we need to put K-bar. So this is how we reduce it. We give traction, then followed by manipulation. So this is how we put the K-words. If you see here, the patient is having fracture here. We need to be very careful by putting K-word because the radial nerve and ulnar nerve is in very close relation to the distal end. So patient has a fracture here. It is reduced and they have passed the K-word, 1 from lateral side, 2 from the medial side. This is how we fix the radius distal humerus fracture or supracondylar fracture by putting the K-words. So what is K-word? K-word, otherwise called as Krishner's wire. They are sharp on both sides. This end is also sharp. This end is also sharp. They come as a threaded. They come as a non-threaded, smooth also. This is plier to bend the K-wire and the other one is K-wire bender. So most of the time, these K-wires are kept in your exam as in the instrument session. So always whenever you are putting the kVARs, we need to put two kVARs. Why two kVARs is important is one kVAR will not hold the fracture. It may hold the lengthwise. There won't be this movement, but this the rotation it won't hold. Like if this is your mirror, if you we have always two hangings to the mirror. We put always two hangings so that it should not go this way, it should not go this way. If we apply only one hanging, then it will rotate like I mean it oscillate like this. So that is the importance of putting two kVARs. It gives rotational stability, it gives stability lengthwise. So whenever you are operating the supracondylar fracture, we always prefer to use minimum two kVARs. So what are the complications of supracondylar fractures? They are common complication for any fracture. We have compartment syndrome, the nerve injury. Most common is anterior interosseous nerve followed by radial nerve. Then ulnar nerve. We get ulnar nerve in flexion type of injury, whereas we get this in extension type of injury. Okay, so this is the complication. Then malunion is one of the commonest complication where you have cubitus varus or gunstock deformity. We'll be dealing with it in next class. Then Walkman ischemic contracture, I already covered this one, and tardy ulnar palsy is also very important. Then we'll move on to one not very important topic, but clinically it is. If you are working in emergency or any other department in pediatrics, you need to know what is this. It's called as pulseless hand after supracondylar fracture. What happens is after the fracture, as I told you before, when there is a fracture, there is brachial vessels going here. So there is pressure over the brachial vessels. It may be either due to the compression, due to the swelling, or either it may be due to injury, complete injury. So if it is just a compression, we have feeble pulse. Feeble pulse. So and if it is injury, there is no pulsation, and hand will appear ischemic and white. So if the patient has pulseless hand, when there is no pulse, so we need to check whether this pulse was there before manipulation, pulselessness, or after manipulation. So if patient came to you in emergency and you have a supracondylar fracture, look for pulse. If there is no pulse before manipulation, then you need to check the color. If it is pink, then there is some vascularity existing. This vascularity may be due to other vessels in and around the other vessels making the anastomosis along the elbow. And if it is white means there is some problem or some near complete compression. So always then you go for manipulation. After manipulation, you reassess the pulse. If the pulse is, if even pulse is not there but hand is pink, you can observe. But after manipulation, if the patient is having before manipulation pulseless white hand, pulseless white, after manipulation it changed to pink, then you can go for observation and just keep watch. But if still it is appearing as a white, then there is this indicate that there is a damage to the vessels. So this patient we need to open and look for the vascularity. So we need the facility or service of vascular surgeon. And if patient comes with normal, I mean a fracture with good pulsation, but after manipulation you feel like patient is having pulselessness, then that is alarming sign. Pulselessness. It's alarming sign that you might have damaged the vessel while you are manipulating. So if you come across such situation, always you need to go for vascular application. So this is how we manage the patient who is having pulseless hand after the supracondylar fracture, either this pulseless hand before the manipulation or after the manipulation. And depending on this pulseless hand is white or pink. If it is pink, we can wait because the anastomosis around the elbow joint is enough to give vascularity for the survival of the limb. But if the patient is having white hand even after manipulation, that indicate that patient needs exploration and we need services of CT surgeon. With this, I finish my topic today. It's very important. You need to listen to it again and again, and please share and like and subscribe to my channels and keep posting some comments. Thank you.